Assalamu alaikum. This is Moed again, the founder of the Golden Board of Urology, where I discuss every case scenario that would come in any final urology board exam. And as usual, besides helping residents with their exams, the ultimate goal behind creating this series is to spread knowledge and experience aiming to improve the patient's care around the world. And as we had in the previous video, I'll run through the case, then everybody who wants to test himself, he can pause the video after each question, trying to answer it by himself, then resume it when he's done answering. But please note that this is 12 to 15 minutes case long scenario, so you'd better set your timers and try your best not to exceed this time limit. And also I suggest that everybody record himself so he can compare his answers with the key answers accurately towards the end of the video. And now let's get started.
A 35 years old male presented to the clinic with a left flank pain for the past month. Pain is not related to movement, and he has no history of fever, chills, renal stones, or any previous urological interventions. His physical examination was remarkable apart from mild left costovertebral angle tenderness. Urine culture was negative. Other laboratory workup were normal. What next? You managed the pain and requested KOB X-ray. Please read the film. What next? CT scan without contrast was done, and please review the CT image and comment about the findings. The image showed a 3 cm left renal pelvic stone in an anteriorly malrotated kidneys. What is the best treatment option and why? What are the possible PCNL complications? List 4 contraindications of PCNL. In this malrotated kidney, how is the puncture site different than the standard PCNL? List 3 methods of tract dilatation. The patient agreed to undergo left PCNL. During the stone fragmentation, around ½ centimeter renal pelvic hole is made with ultrasonic probe. What is the immediate action would you do? On post-op day 2, the patient is stable. What would you do next? Follow-up nephrostogram shows an 8 mm pelvic stone. You stopped the procedure with no extravasation, and hemostasis was good. List 3 options available to deal with the remaining side and left nephrostomy tube. You elected to go for second PCNL. In the third day after the second lock PCNL that you've done, and after removing the nephrostomy tube, the patient started to have bleeding from the tube side. However, he was vitally stable. What's your immediate management? 24 hours later, and despite the conservative management and blood transfusions of 3 packed RBCs, hemoglobin level continued to drop. What is the most appropriate management? CT angio was done, and the patient underwent embolization successfully and was discharged home in a good condition. What is your follow-up plan, and what's next? 1 month later, the patient came to the clinic with a KOB X-ray that showed no evidence of residual stones. Stone analysis showed 80% calcium oxalate monohydrate stone and 20% uric acid component. Plus, the 24-hour urine collection that you've done showed low volume and high uric acid level. What is the specific management you should offer to the patient? And also, please list 5 indications to do the stone metabolic evaluation in general, and what are the indications to do the metabolic stone workup in this patient in particular. Could you please name the stones associated with the following crystals? Could you please mention the types of intracorporeal lithotripters and the advantages and disadvantages of each one? Now with the answers. I noted that so many candidates forget to manage the pain in this question. It's also essential to comment on the radio opaque shadow that we are seeing now, and also lots of candidates used to jump to non-enhanced CT immediately, which is acceptable in the real practice, because for the sake of the exam, something else essential to go step by step. So I wouldn't ignore doing a KOB X-ray or anything else. So to be more accurate, it's better to say that there is a radio opaque shadow on the left renal area or in front of the so-and-so vertebra. And also it's important to comment on the contralateral side that's negative. Next, as everybody knows, CT scan without contrast. Here in the complications, the answers of these questions. Don't do a CT scan or this question is easy. This question is easy, but it's really important not to miss any of the points mentioned. And if anybody has any other points, he can add them to the comments, please. It's essential to follow the patient with the imaging to make sure that he is stone-free. And you can do KUB X-ray as the stone is radio opaque, but I wouldn't say don't do ultrasound or non-enhanced CT scan. Also, it's important to check the hemoglobin level after the bleeding that happened to the patient and the renal profile in general. And also, it's indicated to do stone metabolic workup in this case and to check the stone analysis. Here, the answers of the previous question, and also it is essential not to forget the double J stent in real practice and for the sake of the exam as well, because we've seen so many neglected stents for many years. I got consulted around 2 months back for a neglected or a forgotten double J stent since 2008. We are now in 2024, so this is around 16 years. It's obvious that I'm not the best when it comes to the math. The indication here in the answer. Here in the names of the crystals. Here in the answer, the last question. Thank you.